Our next speaker is Dr. SAARANG HANSRAJ. We'll be speaking on Coats disease in India, clinical features, treatment, and outcome in patients older than 50 years.
Good morning. Good morning, everyone. So I'll be speaking on adult onset Coats disease, the clinical presentation and the treatment outcomes. There are no financial conflicts of interest. So as we know, Coats disease is an idiopathic retinal vasculopathy with often accompaniment with the intraretinal or subretinal exudation, and it was described in detail by Dr. Shields' group. In 2004, the adult onset variant of Coats disease was described in patients who present at age 35 years or later. In a study conducted by our institute a year ago, we found that 17% of patients belong to the fourth decade onwards, and we decided to investigate further into this subset of data. So the aim of the study is to understand the clinical presentation and treatment outcomes of individuals with Coats disease who presented age 35 years or later. And the primary objective was to understand the demographic details and clinical features, while the secondary outcome measure was to understand the treatment modalities and the outcomes associated. It was a retrospective observational study conducted at the tertiary care and secondary care centers of the LV Prasad Eye Network in the 4 states of Telangana, Andhra Pradesh, Karnataka, and Odisha for a period of 10 years from August 2010 to January 2021. The data was extracted from the EMR and then tabulated into Microsoft Excel spreadsheets. Only those eyes were analyzed which were treatment naive on presentation and or greater of age 35 years. Clinical features, imaging modalities, as well as treatment outcomes were then analyzed. We classified the data as per Shields classification from stage 1 to stage 5 as published in 2001. We also classified the abnormalities into 3 regions of the retina, whether involving the macula, whether the posterior-most extent is involving between the equator and the aura and the macula, or if the posterior-most extent is in the periphery of the retina. The anatomical change was then further classified depending on the change at final presentation into whether there was improvement of the disease, whether disease resolved, whether disease worsened, or it was stable. This was an anatomical classification. So 69 patients with 74 eyes presented with and classified for adult onset Coats disease. 16 patients were lost for follow-up at the first visit and were not included in further analysis. Of the 58 eyes, 53 eyes were treated, 2 eyes were observed, and in 3 cases it was deemed that it is best to leave the eye without any intervention. The mean age of the presentation of the patient was 50 years of age, and as we can see, the maximum incidence was seen in the 4th decade of life from between 35 to 44 years of age. Majority of the patients were male, and almost 93% were of unilateral presentation. The presenting visual acuity at baseline was 20/200 or 1 at logMAR. However, 1/3 of the patients had visual acuity less than 20/400 and classified as blind as per WHO classification. Clinically, the most common feature was the presence of hard exudates and microaneurysms. In a few cases, subfoveal hyperreflected nodule and glaucoma was also seen. The most commonly seen stage as per Shields classification was stage 2A, that is exudation not involving the fovea, followed by stage 2B, exudation involving the fovea. On analyzing the angiography, we saw that 89% of eyes had involvement of multiple zones of the retina as per our classification scheme. The classic features seen in Coats disease were the presence of an irregular foveal avascular zone, presence of peripheral capillary non-perfusion, a very well-dilated, prominent dilated capillary bed with micro and macroaneurysms, as well as areas of leakage. OCT showed that the most common signs were the presence of intraretinal fluid and hard exudates. However, the disorganization of the retinal inner layers, as well as the presence of a central peak massive edema, something similar to vein occlusion, was also seen in a few patients. Most of the patients underwent treatment, and the most common modality of treatment was laser photocoagulation with or without intravitreal anti-VEGFs or intravitreal steroid injections. The eyes which did not require intravitreal agents required 1.5 sessions of laser. However, the eyes requiring intravitreal agents required 2 sessions of laser for resolution or treatment. Anatomically, we see that most of the cases, in fact 90% of the eyes, showed improvement structurally with treatment. However, the change in visual outcome was not significant, and the pre and post treatment change in visual acuity was not statistically significant. Even after the final follow-up, 1/3 of the eyes had visual acuity less than 20/400, similar to the baseline presentation. The strengths of our study were that it was a hospital-based study, therefore all the stages of Coats disease could be seen, and it is the largest cohort of adult onset Coats disease as of current literature. However, it was retrospective in nature, and multiple patients were treated with multiple physicians. And since Coats disease is a rare disease, there is no fixed treatment regimen, so that would be a limitation. I would like to conclude that adult onset Coats disease is a rare disease, predominantly affecting male. 1/3 of patients will present with blindness at onset. Treatment is good for structural stabilization, however, visual gains are not significant. And none of the patients of adult onset Coats disease, in contrast to pediatric version, required any intervention surgically. Thank you.
So, since this the number of patients that have been enrolled and examined is stretching over a very vast period, I think almost 10 to 15 years, isn't it?
Yes, doctor.
So, has there been any change in the treatment protocol over 15 years? And do you think changes in the use of different types of anti-VEGFs would have changed the result of your study?
So at our institute, even from the study period, we were utilizing intravitreal anti-VEGFs or intravitreal steroids. And since there's no published literature regarding efficacy of one over the other, it was left to the discretion of the treating physician to treat as they felt pertinent. That is a limitation, but we did not find any difference depending on which agent was used.
But don't you think that over 15 years, the treatment protocol would likely have changed, or were there any changes, or the same consistent protocol was used for all patients for 15 years across different centers, right? It's not one place.
Yes, doctor. The consistent feature of treatment was laser or cryotherapy. Intravitreal anti-VEGF were only utilized if there was macular edema or subretinal fluid did not allow for photocoagulation. So we still, the guidelines or the consistent feature was use of laser or cryotherapy.
Now, what I'm trying to emphasize is that since this was done, the treatment was done at the clinical features and the treatment was done at different centers, there can be some kind of modification or bias because of individual surgeon defining what protocol they would use, because there's no fixed protocol of treatment which was defined in this presentation.
Yes, doctor, definitely. That is the limitation.
No fixed criteria. Normally there are when in a trial, when a treatment is given, there are very fixed criteria. If this is present, then this is the way to treatment, and everybody follows that protocol. Whereas here, this is multi-centric and different surgeons are treating. So there could be a bias produced because of differences of the individual surgeons treating different stages of the disease over 10-15 years.
I agree, doctor. But at the same time, this was more of a real-world study. It's not possible sometimes to follow fixed protocols. But in the course of 10 years, treatment does change, and that is a limitation.
Do you think that at any point you might confuse it with the PCV?
Sorry, doctor?
Polypoidal vasculopathy. Can you think that at any point the surgeon can make a mix-up with the diagnosis, and how to come over it?
One may if one is seeing a patient with old age, massive exudation, but our angiographic features are very different from PCV. We have seen that 89% eyes had multiple areas of zones of retinal involvement. That is highly unlikely in PCV. The macula will be involved. In our cases, 90% eyes involve the extramacular region between the equator and the macula. So angiography, therefore, if there's a dilemma, I think macular angiography will help in that.
Fluorescent angiography.
Definitely. So doctor, when we did the multivariate and univariate analysis, the use of intravitreal anti-VEGFs or steroids was not significant. What was most significant was the baseline visual acuity, presence of subfoveal fluid, presence of glaucoma. These were more significant. The treatment modality did not make a difference. Treatment criteria was on the basis of clinical findings guided by angiography. Treatment of Coats disease has to be with angiography guidance, multiple sessions. One treatment at one time does not lead to resolution. So, and the aim of these intravitreal agents was actually to help in laser, or if there's intraretinal fluid, to help in resolution of the intraretinal fluid.
Do intraretinal patient beyond 35 years also, but here you have quoted like 50 years. So
Yes, doctor. Actually, we had started with analysis of age greater than 50 years of age, but on reviewing literature, we found that it's been defined at 35. Also, patients beyond 50 often belong to the rural centers who are lost to follow-up, and analysis was not leading to any further information.